It's a pleasure to be here. It's an honor to be here. I want to thank both Horst and Torsten for inviting me to be a part of the faculty this year at the Dusseldorf International Endoscopy Symposium. Over the next 15 minutes, which is a very short period of time, I'm going to talk about non-variceal upper GI bleeding, where to from here. These are my disclosures. This is a case, 78-year-old gentleman. He has coronary artery disease. He had 2 stents placed 7 years ago, and he takes low-dose aspirin every day. But he now comes to the emergency department with 3 episodes of melena over the past 24 hours. He's slightly tachycardic. He's borderline hypotensive. He has a hemoglobin of 9.1, and it's known that his baseline hemoglobin is 14.1. So really, what's the correct approach to managing patients who present with acute upper GI bleeding? I really think you need to think about 3 different areas. What should you be doing prior to doing endoscopy? What should we be doing during endoscopy? And what should we be doing after we finish endoscopy? So I'm going to go through each of these 3 parts. So what should we be doing pre-endoscopy management? I'm going to go through this very quickly, given the short period of time. 1, of course, hemodynamic resuscitation, initially using crystalloid fluids IV. We can consider giving blood transfusions. And again, today the recommendations are to use a restrictive blood transfusion policy. So transfusing patients if their hemoglobin drops below 7, or if patients have other comorbidities, especially cardiovascular comorbidities, we should transfuse them when their hemoglobin drops below 9 grams per deciliter. You can consider using an upfront IV PPI prior to performing endoscopy, but it should not delay endoscopy. We should always think about the antithrombotic management. We know this patient is using low-dose aspirin, so we're going to want to hold that, but we should be restarting their antithrombotics, their antiplatelet agents, within 3 to 5 days, because we don't want to lose the antiplatelet effect, especially in a patient like this who's high risk and needs the antiplatelet effect for their cardiovascular prophylaxis. You can consider using a promotility agent prior to endoscopy to clear the stomach of blood and clots, such as IV erythromycin. And last, we should be performing upper endoscopy, usually in most patients, within 24 hours of the time of their presentation. So let's go to endoscopic management. What should we be doing endoscopically, and what treatments are available to us? So really in 2021, we really have all these tools in our endoscopic hemostasis toolbox. Things such as injector needles, so we can inject dilute epinephrine, through the scope clips, coagulation probes. This is a bipolar contact thermal probe, non-contact probes such as argon plasma coagulation, cap-mounted clips such as an over-the-scope clip that we see here, sprays or topical agents such as hemospray, as well as hemostatic forceps. And I'll talk about each of these and show you some videos. So for Forest 1A and 1B ulcers, so these are spurting ulcers or pulsatile arterial bleeders or oozing, per guidelines, combination therapy is recommended. What's combination therapy? Initially, the purist would inject dilute epinephrine, 1 to 10,000, around the area of bleeding to try and slow that bleeding down or stop it by vasoconstriction or a volume tamponade effect. And then you follow that with either mechanical therapy using a through-the-scope clip or a cap-mounted clip, or contact thermal therapy or non-contact thermal therapy using a bipolar probe or a heater probe, or even today there's emerging data that shows that argon plasma coagulation in combination may be helpful. So this is a video here. I think we can all see this is a gastric ulcer, and this is a Forest 1A. We see this spurting bleeding that's going on here. And then what we're going to see here is we're going to take out our injector needle. There's still some bleeding. There's some pulsatile bleeding that's going on there, and we're going to inject around this area with 1 to 10,000 dilute epinephrine. Again, this is going to cause vasoconstriction and even some volume effect of the volume of epinephrine that you put in there to cause tamponade. And then the combination here, at least in this situation, in this case, we're going to follow this up with using a through-the-scope clip. Through-the-scope clip to place it on there, right on that site of bleeding. The clip is released, and that's combination therapy for this 1A bleeder. This is a different video, again, combination therapy. It's a little bit of an older video, so it's a little bit grainy, not as high quality. What we see here is, again, Forest 1A, actively spurting gastric ulcer. You can see there. What we're doing is, again, injecting dilute epinephrine around this area to try and gain control of that spurting, slow it down. We can suction the blood. We can better visualize where we're then going to treat. Now, in this situation, the combination is with a contact thermal probe. This is a 10 French gold probe that's being used here. We're pushing down in this area. This is coaptive coagulation. We're literally trying to weld this vessel closed. You're going to see that takes a little bit of work here, but we're pushing down. You can hold that from 8 to 10 seconds on a low wattage, anywhere from 12 to 15 watts. And then you're going to see we've achieved coaptive coagulation, and there's a post-hemostasis footprint that you can see there. Let's go to the next slide. What about cap-mounted clips? These are becoming more popular. There was actually just a randomized controlled trial that was published as primary first-line therapy that shows that cap-mounted clips appear to be efficacious as compared to mechanical or thermal therapy. What we see here in this video, again, there's some active bleeding here in a prepyloric ulcer. You see the cap and you see the clip that's fitted onto this cap. This was not pre-injected, but it was slowly oozing a little bit of pulsatile bleeding here. This area is visualized. You can suction the site of bleeding here into this clear cap, very similar to a band ligating device. And then the clip is going to be released. We'll see the clip here. It's now released onto this area. This is mechanical therapy. It grabs a large bit of tissue here and stops the bleeding. This is a video actually that was given to me by a colleague, Dr. Maureen Camus. This is a very nice video. It's going to take a couple of minutes to play, but this is a very large duodenal ulcer. It's very large, it's very fibrotic, and it's continuing to bleed. Despite injection of epinephrine, it slows down a little bit. And then you're going to see here that there was an attempt made of using through the scope clips. But because this was so large and was so fibrotic, it continued to bleed. You can see these clips that are there. What was ultimately done, it was decided to use a cap-mounted clip. This was using the Ovesco over the scope clip. And you're going to see this momentarily, but these are through the scope clips that are there, but they're really ineffective. And again, we see this in these cases where you have these large, very fibrotic ulcers, where the through the scope clips just are not as effective because they can't grab the tissue. Now, this video shows how the cap-mounted clip is loaded. So very similar to band ligating device. There's this flywheel that is placed onto the scope. This wire is placed through the working channel, and then there's a little hook on that. We grab the string, and string is pulled back through the scope, just like band ligation. And you're going to see here the clear cap is fitted onto the tip of the gastroscope, and this large bear claw titanium clip is there. It's secured into place here. And then the endoscope is put back down again. The site of the bleeding is found here. There's still some active ongoing oozing here, but Dr. Camus was able to find the site of bleeding. She's able to suction this area, this fibrotic ulcerated area with the bleeding point into the clear cap housing. And then she's going to deploy this clip, which you're going to see here in just a second. Now the clip has been deployed. You see the clip up here. She's going to come back and you'll see it better in the next shot. But this grabs enough tissue that causes mechanical compression of the underlying vessel, and it stops the bleeding. So here you see it here with this big, large piece of tissue that has been grabbed by the over the scope clip. So it was a very nice demonstration. Okay. I just want to also show you a video of another emerging technology, which is a coab grasper or a hemostatic forceps. And again, what we see here is there's a small point of active bleeding here that's going on. These coag graspers or hemostatic forceps are being used a lot in ESD to stop bleeding, or in third space endoscopy, such as in POEM. It's now starting to be used in even in peptic ulcer bleeding, where the site of the point of bleeding is grabbed by the grasper. It's pulled on just a little bit, and then bipolar coagulation can be applied there. If you have a Forest 2A lesion, another high-risk peptic ulcer lesion, such as this is a non-bleeding visible vessel, everybody can see here that there's an ulcer and there's this protrusion that's here. This is the non-bleeding visible vessel. If you're going to use a thermal probe in this type of situation, with or without injection of dilute epinephrine, what you're going to end up having or wanting is you're going to want to have this post-hemostasis footprint here, where we've obliterated this vessel. Always need to be careful in these types of situations. This happened to us probably about a year or so ago. There's this ulcer that's here with this visible vessel, and the gold probe accidentally rubbed the vessel, and we see that it precipitated torrential bleeding here. You didn't see it in the video here, but we injected some dilute epinephrine there. We've slowed the bleeding down. There's still some pulsatile arterial bleeding that's going on, but this is manageable. We go back to our 10 French bipolar probe. We're going to place it over this bleeding area, and we're going to apply thermal coagulation, low wattage, 12 to 15 watts, pushing down, holding that position for 8 to 10 seconds. You can see we're doing that here. And then we've gotten to the point where we finally stopped it. And you'll see here at the very end, there's a nice shot. We've obliterated that vessel, and this patient actually ended up doing well. Okay, what about if we can't gain control endoscopically? Well, we have topical agents. The most common one today is a topical powder. It is hemospray. And what you can see here, this really is still rescue therapy. So this can be used when our other endoscopic hemostasis devices are not being effective, but you need to have active bleeding. So there needs to be oozing or spurting or pulsatile bleeding in order to use this. This really is not effective in clots. It's not effective, or has not been shown to be effective in non-bleeding visible vessels. So you need to have active bleeding. You need to make sure that the catheter doesn't clog. So you want to dry the working channel. You want to disconnect the suction so you don't suction fluid. If the catheter tip does get clogged, you can withdraw it, and you can clip off the end with the scissors and go back in again. You always want to make sure you extend out the catheter far enough that you don't want to have this snowstorm. Sometimes the powder can blow back towards the endoscope, and it makes your visualization difficult. One very important rule: epinephrine alone is not definitive endoscopic therapy and should not be used as such. It needs to be used in combination with either thermal therapy or mechanical therapy. So no epinephrine used alone. What are my technical tips for non-variceal upper GI bleeding? I really think we should be using, if you have it, a large single channel gastroscope or a double channel gastroscope. We need to be able to have water jet capability to use for washing. If you're going to use contact thermal therapy, we should be using a large 10 French probe. That's really what is preferred. For large fibrotic ulcers, you can consider using a cap-mounted cap, such as an over-the-scope clip. For rescue therapy, for persistent bleeding where our endoscopic hemostasis tools are just not being effective, again, you can use a cap-mounted clip or a topical powder as rescue. And I really think today we need to be able to have 24/7 coverage for endoscopic hemostasis with a nurse who has training in endoscopy, and even better if that nurse has training in endoscopic hemostasis and the tools that we use as gastroenterologists or surgeons. What should we do post-endoscopy management? We should put these patients who we treated endoscopically on high-dose IV PPI for 72 hours. We can initiate clear liquids after our endoscopy. We should be testing and treating for H. pylori if we've been treating a gastric or a duodenal ulcer. We always, again, want to think about our antithrombotic management. We want to make sure that for those patients who need to have their antithrombotics started, that they're started in a timely fashion, usually within 3 to 5 days, once the bleeding has been controlled. If the patient has clinical evidence of rebleeding, we should repeat their endoscopy and, if needed, to retreat a lesion. So there's no room today for a scheduled second look endoscopy, only if there's a clinical indication to rescope them. If endoscopy is not working, then we should be referring these patients to interventional radiology. Most hospitals today, large hospitals, have interventional radiology services, so they can undergo transcatheter angiographic embolization. And if interventional radiology is not working and helping, then surgery really is the last resort today. However, today in 2021, 2020, it's very uncommon that we have to send patients to surgery. If endoscopy is not working, we're able to usually gain control through techniques of hemostasis using angiography and embolization. What's in the future? I really think we're going to see over the next 5 years an increased use of cap-mounted clips in treating GI bleeding, especially these larger and more fibrotic ulcers. I think that we're going to see additional topical agents that are going to be used, powders and gels. I think we may even see some of these that we'll be able to use in situations where we don't have to have active bleeding, but I think time will tell. I think we're also going to see hopefully larger and stronger through the scope clips that will try to compete with the cap-mounted clips. I also think we're going to see an increased use of hemostatic forceps, and I'm hoping we're going to see more research data looking at that tool in non-variceal upper GI bleeding. And lastly, we may also see alternatives to PPIs, such as potassium PCABs, potassium competitive acid blockers, but we'll have to see. I want to again thank the organizers. I want to thank Horst and Torsten for inviting me, and thank you all for your attention. And I hope you enjoy the conference. Thank you very much.